I see folks are joining. You are most welcome. We've just opened the line a few minutes early to let people get settled for the webinar today. Thank you so much for joining. All lines are muted as you join, so if you have a comment or want to say hello, please enter it into the chat box and please select to all panelists and attendees so we can all see your greetings. Thank you all for joining. This is Christine Toriuson speaking, by the way, from FHI 360. And we have a number of great panelists with us, but we are keeping the lines muted and using the chat box. I see lots of people joining. Welcome, Marion and Alfred and Godswill and, oh, Marlon, sorry for that. Excellent. You know, these are crazy times and we're very appreciative that folks are taking the time to join us today. I feel like I should have a running commentary, so as people join, they know that this is not an empty space. So those who are joining now, welcome to the PrEP Learning Network. We're just going to keep waiting a few more minutes for more folks to join. Greetings to Charlton from Zimbabwe. So for those who are newly coming on, you are in the right place. We are just waiting a few moments for everyone to join. You're welcome to use the chat box to say hello. We'll begin probably, I think, about 1 minute after the hour. Hi, Samuel. It's good to see you. We have some folks who are regular attenders, and we've been on many of these webinars together, and some new folks. Welcome to all. This is the PrEP Learning Network, and we're going to be starting in just a minute. We're having great representation. We have folks from Nigeria and Uganda and Zimbabwe. And if I scroll up, I'll see where else. From Mozambique. Thank you all for joining. Okay, I think I'm going to go ahead and begin, even though I know people are still coming onto the line. So my name is Christine Toriuson. I'm at FHI 360, and this is the PrEP Learning Network, which is hosted by Options, EPIC, and RISE, and is funded by USAID through PEPFAR. And we're very grateful for you joining today, even in the midst of all the difficulties that we're facing globally with coronavirus. But we do think that it's that this is still a very important issue. We had actually thought to ourselves, should we, in the midst of all the stressors and priorities that people have right now in responding to COVID-19, we wondered if we should continue this network series, but we realized that this is an incredibly important topic in this time, this issue of addressing intimate partner violence in PrEP services. We have already seen reports coming through from China and Italy and the US and other countries that there is an increase in abuse as people are isolated together or have increased financial stress or decreased control during this lockdown period. So we're very, very concerned in particular as people move into shelter in place or stay at home measures that women and other populations may be restricted at home with an abuser, that this social distancing and the restrictions on travel may make it more difficult for them to leave or to access social support. We know from other epidemics, such as the Ebola epidemic, that folks are at increased risk of abuse and exploitation during a time like this. And we also don't know how difficult it may be for PrEP users who are hiding, who have not disclosed their use to partners, to continue to take their pills daily or get refills if their partner is constantly at home. So there are many, many challenges faced right now, and a higher risk of violence in this context. So the guidance we're going to go through and slides that we're going to go through today were developed prior to the COVID-19 pandemic. We had started preparations for this webinar months ago, but the fact that we are now in the middle of this pandemic really brings into focus how important this is. And so, we hope that the discussions today will help, at least for those who can interact with the healthcare system in some way, that they would still be able to get support for IPV and GBV. We're going to actually start with a survey. So I'm going to ask you, Aubrey, to launch that. So this is a one-question survey, and so I would ask you to please just go right ahead and click a response. I'm going to just wait a few moments for folks to do that. And I'm going to leave this survey up for just a moment here while I just read you a quote from a New York Times article. It says that we know that at any time an abusive partner may be feeling a loss of power and control, and everybody's feeling a loss of power and control right now. It could greatly impact how victims and survivors are being treated in their homes. That was from Katie Ray Jones, the Chief Executive of the U.S. National Domestic Violence Hotline here in the U.S. So that is just to highlight the importance of our topic. I think we'll go right in now and hear from our presenters. Can we close the poll? Thank you. So for those who have joined late, I'll just introduce myself again. This is Christine Torjussen from FHI 360, and this is the Options, EPIC, and RISE PrEP Learning Network. So this is an overview of our presentation for today. We're going to hear from USAID on the new requirements for addressing IPV and PEPFAR-funded PrEP programs. We're going to hear from a colleague in Kenya on how to address IPV and PrEP counseling. And we're going to get a sneak peek of a new intervention developed by the Charisma project that addresses relationship dynamics and IPV for women using PrEP. Continue, please. So our speakers today, our first speaker will be Amelia Peltz, who's a Senior Gender Advisor at the Office of HIV/AIDS at USAID. Our next speaker will be Anne Ngunjiri, who's a Senior Technical Advisor at LVCT Health in Kenya. And our third speaker will be Michelle Lanham, who's a Technical Advisor at FHI 360. Just a little bit of housekeeping before we begin. We have a dedicated Q&A session at the end of the presentation. You might notice that all your lines are muted. I apologize for this, but it's the best way we can keep the line clear for our speakers. We're asking you to please enter your greetings into, or your questions into the chat box. I notice a lot of folks are sending chats to the all panelists, which unfortunately is the default setting in Zoom, but you can, under the to line, you can click on a little arrow and select all panelists and attendees, and that way everyone can see your questions, and that will help keep the discussion moving through the chat feature. Next slide. Okay, we're gonna go right in and start with Amelia. Over to you, Amelia. I'm not hearing Amelia.
Great. Can you hear me now?
Now I can. Yes, go ahead.
Oh, okay, terrific. Thank you. Good morning and good afternoon. It's a pleasure to join all of you and sending you all greetings, warm greetings during this very, very challenging time in which we find ourselves. So if we can go to the next slide. Thank you. So we know that gender-based violence is one of the most critical barriers to reaching HIV epidemic control. Globally, WHO data has shown us that 35% of women will experience intimate partner violence or non-partner sexual violence in their lifetime. We've also seen that women who experience intimate partner violence are 1.5 times more likely to acquire HIV. The experience of intimate partner violence has also been found to lower adherence to highly efficacious prevention methods such as pre-exposure prophylaxis, or PrEP, that we're going to be talking about today. And women living with HIV also experience heightened levels of violence, including high rates of violence associated with disclosing her HIV status. The violence poses a very substantial barrier to the effectiveness of existing HIV strategies and really undermines an individual's ability to take up and adhere to important prevention and treatment options. Go to the next slide, please. Thank you. So this is an illustrative example of the types of gender-based constraints that are facing individuals along the HIV clinical cascade, as well as in HIV prevention. Now, while these issues manifest themselves in different ways across the cascade, they are fundamentally rooted in socio-cultural norms that endorse inequitable power and decision-making, the acceptance of the use of violence, particularly men's use of violence, stigma and discrimination, particularly against key populations and LGBTI individuals, and social constructions of a gendered identity that really shapes what is considered acceptable and what is not. Next slide, please. So sometimes addressing gender-based violence is seen as a standalone issue that's separate from HIV. But we know that GBV and gender inequality impact each element of this cascade and impede the effectiveness and the success of our programs. As such, preventing and responding to GBV are essential to meeting PEPFAR's 95-95-95 goals. Now, PEPFAR is primarily focused on intimate partner violence, sexual violence, and violence against children because of the proximate relationship to HIV. Another important point I really wanted to emphasize is that it's important to understand that the baseline prevalence of violence in the countries where we are all working, particularly in sub-Saharan Africa and Southeast Asia, is extremely high. It's important to remember that sometimes these regional averages where we see, 1 in 3 women or 1 in 4 women, they can mask also very important in-country differences. So it's really important to understand that we are already working with populations that are experiencing high levels of violence. And this means that we really need to adjust our service delivery approaches to reflect this reality. And this means, in the most practical terms, we need to be able to identify individuals who are at risk of or currently experiencing violence in order to get them the help that they may want, which will ultimately support their HIV prevention choices, particularly PrEP. Could we go to the next slide, please? Thank you. So I wanted just to talk very, very briefly about some of USAID and the Office of HIV/AIDS priorities around addressing gender inequality and prevention and response to gender-based violence. We have 4 technical priorities, but today I'm just going to focus in on priorities number 1 and 3 with a specific focus on PrEP. So next slide, please. Thank you. So this slide is talking about both index testing and PrEP. And so what we've identified is that it's essential that all testing sites, focusing on index testing, but also all PrEP sites must be able to implement routine inquiry for violence, which is sometimes known as, also called GBV screening, as well as provide support and refer survivors of violence to appropriate GBV response services. Now, I wanted just to make a quick distinction between the purpose of screening for violence, the difference between index testing and PrEP. For PrEP, the reason why we want to do this is we want to be able to identify individuals who are experiencing violence so that healthcare providers can help them with and offer supportive services. So this is to address both their immediate needs for GBV-related care, but also help them to adhere to PrEP for the period of time that they want to do so. So in this way, identifying survivors of violence in PrEP services is really meant to serve a dual purpose, but with the common goal of improving the client's health and HIV prevention outcomes. Now, this is different from the reasons why we would do this in an index testing related service. In index testing, doing this kind of routine inquiry for intimate partner violence, or GBV screening as it sometimes is called, it's really done in order to ensure that we are not putting a client at risk when we are conducting partner notification services. Next slide, please. So this is to further examine the evidence around intimate partner violence and PrEP. This is a slide that highlights several key important points, namely that IPV really is associated with lower oral PrEP uptake, increased PrEP interruption, and lower adherence to oral PrEP and vaginal ring use. In addition, qualitative research has shown that IPV resulted in stress and forgetting to take pills or leaving home without pills, and partners throwing those pills away. And this is really important evidence that shows that the barriers that violence pose to individuals who want to take PrEP are quite formidable. And I think this is also a very stark reality that we need to bear in mind, particularly in this complicated situation of the COVID-19 pandemic, when many individuals are now much more isolated and facing situations where they need to be taking medications, but that it might be very difficult under the circumstances in which they find themselves. Next slide, please. Thank you. So this is the third part of OHA's gender and GBV strategy, and it's really focused on improving those linkages between community prevention interventions and clinical post-GBV care services. We really feel it's important to bridge that clinic and community gap and help to link people to both PrEP and to IPV services. We want to ensure that anyone who is doing work in the community, working with individuals who either are on PrEP or who we are identifying as good candidates for PrEP, are able to respond appropriately if they're working with someone who may disclose that they are experiencing violence in their relationship or that they're afraid. We want to ensure that all of those community-based workers know how to respond and are able to then direct someone to the services they may need, whether that be doing sort of a warm referral or having referral cards or information that's available. We also want to be ensuring that the linkage goes the other way, is that for individuals who may have presented at a one-stop shop or some kind of dedicated post-violence care service site, are also referred to important HIV prevention interventions, be they in the community or to initiate them on PrEP if they should so choose to do so. So we really want to make sure that those referrals and those connections are going in both directions. Next slide, please. So this is a slide that illustrates what some of these minimum requirements are for sites that are going to be asking about violence in the context of PrEP services. And these are based on the WHO guidance, the 2013 guidance and the 2014 guidance, Healthcare for Women Subject to Intimate Partner Violence. And so I'll go through these fairly quickly and certainly happy to answer questions on them later. But the minimum requirements as outlined by WHO that need to be in place include ensuring that providers are able to offer first-line support to anyone who discloses violence, ensuring that there is some kind of standard operating procedure for asking about the fear or experience of violence so that everyone who's working at a site knows what the roles and responsibilities are. Having a set of questions where providers can document responses. Having this set of questions is important because sometimes individual biases can creep in when asking questions, and thereby having something that is a bit more routine is important to help try to reduce some of that bias. Wanting to make sure that providers are trained on how to ask about it. It's not an easy subject to talk about, and it can make a lot of providers understandably very uncomfortable or nervous. And so having that training and that practice, being able to ask questions and have a dialogue with a client about their lives is extremely important. It's also essential that we ensure that these conversations are kept private and kept confidential, that the setting where they are conducted is private, that no one can hear, and that the client is reassured that the conversation is confidential and would never be disclosed without their explicit consent. And then finally, wanting to ensure that there is some kind of process for offering referrals or linkages to other services in place, knowing that not every site is ever going to be able to provide all of the services. So we want to ensure that we have resources available where we can direct individuals for additional support. Next slide, please. So this is the last slide I'm going to speak to before passing it to our next presenter, but I wanted just to focus in very quickly on this, this first line support, because this is a really critical piece of this work, in that we cannot be in a situation where we are asking someone about violence and then not being able to provide a response. That we know can cause additional harm and additional trauma to individuals. And so it's really important that anyone who is working with clients who may be experiencing violence or who is in a position to be asking about violence needs to be able to provide some very basic first-line support. And first-line support is not the same as a full, provision of clinical care, but this really is that sort of psychosocial first aid, if you will. It's that sort of immediate, compassionate, caring response that a provider might offer to someone. It also involves doing a safety check to discuss how to prevent someone from further harm if they are at an immediate risk. And this first-line support has been, the WHO developed a very handy acronym called LIVES, and the LIVES outlines the 5 different elements of what this first line response really looks like. And as you'll see, the first 3 elements of it really have to do with the communication and that compassionate response and providing that reassurance and that psychosocial support. In addition to that, it talks about how we want to do an immediate safety check to ensure that someone is not in any kind of immediate danger that would need to be addressed, and also connecting the individual to services and other kinds of support. So from there, I'm going to pause and happy to answer questions during the Q&A period, and passing it to our next speaker.
Thank you so much, Amelia. And now we can move over to Anne to hear about how she has applied some of these principles in Kenya.
Thank you. So I'll just give a thank you for the opportunity, and welcome to the second part of the webinar. I'll just give a very quick brief on what we particularly do in LVCT Health. LVCT is an indigenous NGO that has been delivering HTS services since 2001 and implementing GBV and BAC programs since 2005. And our key beneficiaries and the clients that I'll be referring to in the presentation are adolescent girls and young women, men who have sex with men, female sex workers, people living with HIV, the LGBTQ group, and survivors of GBV, and also fisher folks. So as Amelia has presented on the USAID requirements for integrating IPV into PEPFAR-funded programs, mine will be giving a more pragmatic sense of how it is that we actually do it across all our sites in LVCT within the 27 counties that we are based, and also share some of the good practices that we've learned on GBV HIV integration, which I hope can be applicable in any other resource-limited setting serving the same populations that we serve. Next slide, please. So on this slide, it gives a snapshot of the typical scenarios that our PrEP providers have come across whenever they're having a consultation with the clients. Some of the scenarios, home dynamics, relationship dynamics that the PrEP clients disclose to the service providers on the things that affect their PrEP uptake. And a common one that would come up a lot would be the clients experiencing intimate partner violence, which, as we've been told earlier, would affect their adherence to taking the daily pill, the PrEP daily pill, or even for those who are coming for HTS services or not, others accessing the services because of the risk of social harm at their home. So from a service provider perspective and from an organization perspective, it became very clear.
And we suddenly lost sound. Anne, are you there? This is, of course, a challenge. Anne is calling in from Kenya, and who knows what's going on with the internet. So, yeah, we do not have sound right now. Can you all hear me? This is Christine. Can you hear me speaking?
Yes.
Yes, we hear you. Yes, we can hear you.
I think maybe what we'll do is let's give Anne a moment to try to reconnect. And do you think we should, it looks like Anne has dropped and is going to try to reconnect. Do you think we should hold, or do you want to, Michelle, go over your slides while we're waiting?
Maybe let's just give her 1 minute, and then if she doesn't come back on right away, then I'll jump in.
Okay, that's great. I see a question in the chat about PowerPoints, so I will just say that yes, all the PowerPoints will be available after this webinar, and as well as a recording of this webinar, as well as a resource sheet with additional materials. Maybe I can ask a question of Amelia now. I think there was a question that came from...
Hello?
Oh, hello, Anne, you're back. Anne, we can hear you now. Anne, can you hear us? All right, I heard you greet us, but now I'm not hearing anything.
Hello?
Yes, Anne, I
Hi.
can hear you.
Oh my God, I'm so sorry. It seems up is low. Yeah, sorry. The lights just got out. Yes, I can hear you.
You have our total empathy. No one here, everyone here is just grateful that you were
Hello?
able to reconnect. Yes, we can hear
I'm
you.
so sorry. The electricity, we've just had a blackout.
Oh
But
dear. Please go ahead, Anne.
Okay. Okay, so shall I carry on, or do you want to answer
carry
the questions
on.
that were being asked?
No, please carry on.
Okay, I'm hoping I won't break up so much and I'm loud and clear enough. So sorry about that. I was just going through some of the typical scenarios that our providers go through and taking PrEP.
And you are breaking up.
A common story that was partner violence. That would hinder them from taking PrEP.
And unfortunately, you're breaking up, so we're only hearing half sentences. Sarah and Aubrey, do we have an ability to dial out to a landline for Anne or her phone from Zoom?
I am not sure about that, but I am sharing my screen, so I can't get to.
I see.
Do we have, yes, I can do it. Do we have a phone number? Can you send that to me?
Could, let's see. Katie,
can
you get a phone number from Anne for Sarah? And then in the meantime, Rogeru, are you on the line and by any chance willing to try to go through Anne's slides? Oh, Rogeru does not have, can I promote Rogeru to panelists?
Yes.
Rogeru, how do I do that?
I might have to do it. Hold on, let me do it.
Oh, and all these wonderful people are sending the toll-free numbers to call in. I love it. So Anne could also call in from a toll-free number.
Absolutely.
Okay.
Juliana, I'm sending you Anne's phone number right now, or I can try to connect her here as well.
I really appreciate everyone's patience. This is the world we live in. All right, so let me know when. I think getting Rogeru over to panelist would be the first priority, Sarah.
Is it his name?
Rogeru.
Got it. Thank you.
And I'm going to ask Amelia while we're doing that to answer the question about routine inquiry, which is, what are the steps for conducting routine inquiry?
Hello, can you hear me?
Sure.
Oh yes, I have Rogeru. Rogeru, are you willing to jump in?
Yes, I am hoping that Anne will be able to reconnect as soon as possible. So should I just say next slide when I'm ready for that as we go along?
Yes, please. Thank you.
Okay, so I'll just pick up directly from where Anne left off, which was lessons learned by PrEP providers across our sites as LVCT Health. So number one would be that we should not coerce clients into any of the decisions that they make. That's a general principle, and it certainly applies to PrEP. The objective is to enable her and empower her to make an informed decision, to help her correctly perceive her risk for HIV and understand why this would be a beneficial method of HIV prevention for her. Bearing in mind that in a lot of circumstances, a key advantage of this in the context of IPV would be that this is a method that does not absolutely require you to share with your partner that you're using it. In that vein, you can also repack the medication in an envelope or another discreet manner for your client, other than having them to carry it in its distinct packaging. Very importantly, you should always appreciate that you need to take time with your clients in order for them to be able to open up about these very sensitive issues. This is particularly relevant when you're working in the context of informal settlements where confidentiality is such an important issue, having been seen by your neighbors and people in the community going to the clinic, and leading on to that, there should also be that, building on from that, there should also be that appreciation that there should be ongoing contact with this client. So this is an issue that you'll need to sort of explore time and time again. we've learned that some clients will confidently take PrEP having hidden it in their houses. And once in a while, clients whose partners visit once in a while won't disclose to them that they are using PrEP. Only a few male sexual partners are aware that their partners are on PrEP. This is all around socio-cultural norms, and I think the point that we're making here from these points is the issue of disclosing your PrEP use and how there's an advantage in PrEP that you don't have to, and commonly people will choose not to disclose their PrEP use. And even condoms in marriage is something that's not discussed. And another important thing to discuss with them when you're initiating PrEP use is that what anyone would advise when anyone is starting on PrEP, which is that for those first 7 days leading up to the full efficacy of PrEP, abstinence/use of condoms is required. That is not something that is always feasible, especially for those who are in marriages or long-term relationships. So that's going to be an issue that you're going to have to navigate with your client. Next slide, please. So in relation to the Set GBV screening questions that I used across our sites, in regards to physical violence, the question to ask here is, within the last 3 months, has anyone ever hit, punched, kicked, tried to strangle, slapped, or hit you with something that could hurt you, or has done anything else to hurt you physically? In regards to emotional violence, within the last 3 months, has anyone threatened, cursed, insulted, done things that made you feel ashamed, kept you in a state of fear, or humiliated you in front of others? In regards to sexual violence, the question to ask is, within the last 3 months, has anyone forced you to have sexual intercourse with him, her, even when you did not want to, or forced you to perform other sexual acts you did not want to? An important note here is you should not ask those questions the way I have just read them out now. Of course, they need to be asked in a more sensitive manner, building on the point that I made from the previous slide, just taking time to talk through these issues with a client. And you don't have to follow things in sort of a set order of questions. You just deal with things as they arise organically, aiming to cover all these different types of violence. I see a message saying Anne is back on the line.
I do see her on, but I don't hear her. Anne?
I'm trying to connect via the phone.
Yes, we hear you.
Oh, you can hear me now?
Yes.
Oh, okay. I'm sorry about that technical hitch. I just had Reggie was going through the Set GBV Screening Questions. I believe that's where we are. Okay. I'll try and catch up for the sake of time. So as you will think, those are the three typical forms of violence that we tend to screen for: the physical violence, as it's written there, the emotional, which asks about cases of being threatened, cursed, or insulted, or if your partner is keeping you in a state of fear or humiliation, and the sexual violence ones as well. But just to reiterate what Rodero said, some of these questions from my experience, they might come across a bit abrupt when you're asking a client, especially the first time that you're asking them when they come to the clinic. So what we've done as LVCT is still maintaining this as our job aid for the service providers. If you could just go to the next slide, please.
And you are quite muffled. Is there any way to get clearer or no?
Am I clearer now?
Yes, you are.
Okay. So as I was saying, in the next slide that says asking about questions, how to raise the subject carefully, what we've done is we've trained all our HTS service providers and any other cadre who are allowed to do the screening on how to have a high index of suspicion of violence occurrence. So by this, what we've taken them through is how to observe the physical appearance of a client for any telltale signs of violence that they may be going through, or even in some cases observing their behavior. And this would give an indication of whether there might be violence that they might have experienced or not. And then now they can go to the statements that are in the slide, asking or making statements like, how are things at home? How is your relationship? And sometimes the partner we care about can hurt us, have happened to you. And the main point of asking this in a gentle, softer manner is you want to create rapport with the client you might be seeing for the first time or not. But essentially what you want to do is you build that trust with the client, even as you're offering the HTS services and the PrEP, so that they can be able to disclose to you if they've undergone any violence at all at home that may impede or act as a hindrance to the uptake of services, or if they actually need referral services beyond the HTS services, so for GBV services more specifically. So what we've done is we've trained our HTS service to have a high index of suspicion constantly whenever a client presents to them. You can go to the next slide, please. So once when the client is in front of the HTS provider and they do confirm that they've actually gone through violence, as has been said in the previous presentation, and we've taught all our health service providers, HTS service providers, our counselors particularly, and clinicians on how to order lives. And again here, it presents another set of questions that you can ask in the creating rapport session during your consultation. Are you afraid of your partner? And does your partner bully or insult you? Because at the end of the day, what we train them on and what we always emphasize on is we do not serve HTS in silo to GBV. Both issues need to be addressed within one consultation. So some of the other questions are, has your partner ever forced you into sex or forced you to have any sexual contact? So it's still the same 3 questions that WHO recommends, but we're just asking them in a way that would create rapport with the client and for the client to actually be able to disclose that they have undergone through it. And if they have, again, our service providers are obliged to offer lives. And if they have not, then what we do is we still give GBV prevention messages that are appropriate to that client, and we emphasize the need of, should they feel that they're at risk of experiencing any form of client, then we are there to help them. So it doesn't have to take for their next review for them to come in. They can actually come in and self-report in between and be able to offer them the services that are required to address their GBV risks or post-violence that they may have occurred. Next slide, please. So more specifically for PrEP, this is a slide titled Counseling Women on Whether PrEP Disclosure is Safe, as I don't have access to the webinar now. But so more specifically for PrEP, once a clinician has established that the client is eligible for PrEP, then now this would be the questions that they would tend to ask as they're prescribing PrEP, just to see that whether there's any IPV happening that might, again, hinder them from adhering to the daily pill or coming back for their pills, for their refill pills. And if the client does disclose that they have undergone violence, as earlier mentioned, the service provider is obliged to give lives. And the last S in lives is offering support, which for us, it means referring appropriately for the care that that client would need in terms of addressing their GBV experience. So at this point, LVCT will offer the medical assistance that they may need, again, observing the national standard operating procedures for post-violence services, which are in line with the USAID requirements, and will also be able to refer the clients appropriately to the services that they need. So the next slide, please, gives a clear breakdown of how it is that we actually do our referrals across all our sites. And this is the establishing referral pathway slide. So there's 5 critical steps that from day one we emphasize on, and we make sure that all our service providers, all our sites have conducted before we actually started offering GBV services. So this was at the onset. And the first one, it says it's to identify and map available services or organizations. What has worked for us is we use our local administration services, what we refer to as chiefs within the areas where we work with. Chiefs tend to know most organizations working within that locality, what services they offer, and more often than not, the focal person who the head of that organization is. So once we go to the chief with a list of services that we know a GBV client would probably need for post-violence management, we can then go to the location of where that organization is and conduct an entry process there, and also be able to meet the focal person whose details will take. And not just the details of the focal person, but also more specifically what services that they're actually able to provide, and their opening hours. So whenever we are referring a client to that specific site, say for example, if you're referring to the children officers' offices within that locality, we'll be able to tell you who the person is, what hours they are available, and what is their reachable number should we refer a client to them. And with their physical location in hand and the contact details as well, we are able to create a living document, a directory list. This always changes because what we've also seen is in some of our referral points, there tends to be a high staff turnover. So every time we are alerted that somebody might have changed, or every time we call the focal person and they might have left the organization, then what we do is we actually go back to that facility again and do a sensitization with them. It's like a meet and greet with them and get to know each other. So we tell them what it is that we offer for GBV clients, survivors, and how we also see what they can offer for the same clients. So we're able to connect with them and collaborate, and also explain to them that there are instances when we will be sending clients to them and what it is that we'll be telling the client should be expecting from the referral point. So that it's very clear that if I send somebody from LVCT to organization X, Y, and Z to the children's department, my focal point will understand what services are already provided for the survivor and what it is that they're supposed to do as well. And we tend to do these sensitizations across the multiple sectors. So we tend to refer a lot to the police stations. So we do a lot of sensitizations with police officers. We do sensitizations on GBV management with the children's department, with any other health facility where we may need to link, or with any other health facility who may refer clients to us. We're just able to sort of develop an MOU where we understand each other's roles in terms of addressing this client holistically, so that you're sure that by the time you're sending somebody to point X, Y, and Z, they'll be able to get the services that they require. So from the directory list, it's informal or formal agreement with the focal points, and that way we also have the referral tools that we use, and this is mainly for tracking, because at the end of the day, if a client presents to us as LVCT, it's our mandate to ensure that wherever we have referred them to, they've actually completed that linkage, they've actually reached that service delivery point, and they've gotten the services that we have referred them for. So we have a referral tool that is able to track that from the point that you refer that client, what services they got there, and also what we expect from our clients since they're within our locality is when they're coming back for their follow-up visit, they bring back this document that shows that they actually reached at the referral point and they got the services that they require. That way we can tell who's lost to follow-up perhaps, who's not reached their referral point, and who has what additional support they may require. So that's how we ensure that we've established effective referral pathways for all our clients. Next slide, please. So how we do offer our warm referrals in the case where now we actually have to refer a client is, since we have, again, the focal point contact numbers, what we tend to do, say, if you're referring to the police station, we normally have the number for that specific police officer who sits at the gender unit, gender desk, and we actually call them and tell them, I'm sending clients X, Y, and Z to you. This is a scenario that they've given, and this is what we have offered them, and this is what they'll be expecting from you. Again, this is building up on the sensitization that we have done with that group of people. And what we also make very clear for our clients is that there's shared confidentiality. and that anybody who's involved in their care plan, their care pathway, that they would allow us to explain to the next referral point what it is that they've presented to us with and what services they may require. Again, this reduces the burden on the client of having to go to the next service delivery point and repeating the same story all over again, which has it's shown that they become more traumatized, and even the thought of having to go and repeat the same story somewhere else, some of them do not reach the referral point. So right from the onset, once they disclose that they're actually undergoing violence, we do make it clear to them that there's an element of shared confidentiality. And as much as they've trusted us, we hope that they'll trust the next service delivery point for them to be able to receive the services. So what we actually do is we call the next service delivery point and tell them that they'll be receiving client X, Y, and Z who will be coming on this day at this time. It has to be at the convenience of the client, but also we bear in mind that some of the services that are offered are time-bound. So we have to respect both things, that the client wishes to go at this time, and it has to be within that time period for cases specifically for sexual violence. That way, the referral point will be ready to receive them. What again we do say is for cases of especially sexual violence, if there is normally a queue, that will be fast-tracked so that they don't have to wait there. And also for children as well, in case they've undergone any form of violence, then they have to be given priority. So at this point, the next service delivery point, do understand that by the time somebody is coming from LVCT Health, there are certain actions and protocols that need to be observed, and they're okay with, and they accept it as well, and it's feasible. And that way, we are also assured as the people who've referred that our client has been treated in a humane manner by the time they're going to the next service delivery point. That way, we are able to address both the PrEP services that they did come with and address their GBV needs as well for post-care management. The next slide is on the key messages. And what it says there is routine inquiry may reduce women's need for health services and may save time and resources by helping providers understand the need for integrating IPV and HTS as well. As we've seen, there's a wealth of evidence that shows the interlinkage, and there cannot be issues that are looked at in silo. We have to look at them together and address them at the same time. Their care pathways might be different, but at the end of the day, it's our mandate as service providers in our university to address their GBV concerns as a client seek any other service that we might be offering. And the whole reason for the routine inquiry, which we do quarterly, is to help identify survivors early enough before the violence actually escalates, impeding their PrEP access, uptake, and use as well. And the number one key thing that we always insist on, and we also train our service providers on, is observing the principles of survivor-centered approach, that you have to ensure that the survivor's best interests come first. You're not placing them at additional risk. You're ensuring their safety, their confidentiality, and privacy, whatever they disclose to you, is kept to you and any other service provider in the care pathway. And also that for the referrals that they might be given, we follow up, or we do follow up to ensure that they've actually reached their service delivery points and gotten the services that they need. Thank you very much. The next slides are the key resources, additional resources that you may refer to for additional information. And I'm sorry for the technical hitch. Thank you.
Thank you so much, Anne. I appreciate it. And I know the sound was a little fuzzy, but I'm very glad that you were able to present, and we have gotten a lot of great questions. I am going to turn over to Michelle very quickly to tell us what the Charisma intervention is, and then we will try to address some of the questions. Thank you.
Thanks, Christine. So Charisma is a 5-year project funded by USAID and PEPFAR, and it's led by RTI International. We're in the final year of the project, and I'm going to give you just a very brief overview of Charisma to let you know our approach to addressing relationship dynamics and intimate partner violence with women using oral PrEP. And this will be very brief because there will be a full webinar on Charisma later this year. Next slide. Charisma stands for Community Health Clinic Model for Agency and Relationships and Safer Microbicide Adherence. And Charisma aims to improve PrEP adherence by promoting women's ability to decide if, when, and how to involve male partners in PrEP use, Secondly, by improving women's ability to communicate and negotiate with their male partners about PrEP and HIV prevention. Third, by screening for partner violence and supporting women who are experiencing violence. And finally, by increasing men's awareness, acceptance, and support for women's use of PrEP. Next slide. Charisma is an empowerment counseling intervention implemented by lay counselors, and this figure just gives you a snapshot of the overall intervention design. I'll give you just a few details about that. So step one is a relationship assessment, which you see in the dark purple box. We've developed the Healthy Relationship Assessment Tool, or HART, which screens for violence and also assesses other aspects of a woman's relationship. A lay counselor administers the HART on a tablet, which calculates a score at the end. Step two in the large light purple box is counseling, which is tailored to each woman's individual situation based on her HART score. If you look at the blue box, all women receive Module A, which covers characteristics of healthy and unhealthy relationships. And after that, you'll see Modules B, C, and D in the green, yellow, and red boxes. Each woman receives just one of these three modules based on her specific relationship situation. Any woman who indicates she's experienced any form of abuse or control in her relationship receives Module D on intimate partner violence, which is in the red box on the right. And I'll save the details of exactly what that includes, but it's quite comprehensive and good. And then women who do not report any violence receive either Module B or C if she has not told her partner that she's using PrEP, or if she's told him and he's unsupportive, she receives Module 2 in yellow. And the counselor helps walk her through that decision of whether she wants to talk with her partner about PrEP. If she does, then they strategize and role play so that she's prepared for that conversation. And if she doesn't want to tell him, then the counselor helps her strategize how to use it without his knowledge. Finally, all other women receive Module B on partner communication, which you see in the green box, and that's skills building activities around communication. We also have videos that go along with several of these modules that the lay counselor shows as part of the counseling session. And at the end of counseling, step 3 in the gray box is offering the woman print materials on PrEP and HIV prevention that she can share with her male partner, along with a letter inviting him to come to the clinic. And that's to increase his awareness and support and help facilitate conversations between them. Finally, step 4 is offering the woman referrals to any additional services that she needs. Next slide. We are testing the intervention in a randomized control trial with 407 women using oral PrEP at the Wits RHI clinic in Johannesburg. Just because of time, I'll skip the details about the 2 arms and the outcomes, but it's all very clear, hopefully there on the slide, about the basic RCT design. Because of COVID-19, we're closing the study early, about a month early, and the Wits RHI staff have been quite busy last week and this week to try and get as many participants in as possible for closeout. They've all been offered a 3-month supply of PrEP and contraception at their final visit. We're expecting to present the RCT results in July 2020, and we've also developed a comprehensive toolkit for PrEP implementers to support adaptation and implementation of the Charisma intervention in other PrEP programs. And that includes training for staff, it includes a counseling manual, a counseling job aid, and a number of other tools. So we hope that that will be quite useful. I will stop there so that we have at least a few minutes for questions.
Thank you so much. I just want to assure everyone, I know we're close to the hour, but we have a list of all the questions, and we will create a resource sheet and address those that we don't get to. I think I can very quickly, I answered in the chat, there are a lot of questions about taking PrEP outside the bottle, and that we have stability data that makes it possible to do that for up to 6 weeks as long as it's not exposed to direct sunlight. There are also a lot of questions around why the presentations have focused on women, and do men also experience IPV and GBV, which the answer is of course yes, and wanting to have a little bit of that male partner or male perspective. So that was just a generic overarching question. I will punt back to the presenters, but I also want to get at some of the ones that are specific such as what are the steps for conducting routine inquiry, how do we address issues of support where the client will not disclose, accept assistance, or take up PrEP because of economic dependence on the perpetrator, and how do we manage our referral systems when they are weak, or how do we do sensitization with referral providers? So I'm going to punt those over to our presenters, our panelists. Who would like to start?
Hi, this is Amelia. I can just address some of these very quickly, but we'll want to really defer to our LVCT colleagues who have expertise in this area. With regards to the steps on routine inquiry, I would say that the presentation from Anne and Ruggiero from LVCT do an excellent job at outlining all of the steps and all of the pieces that are necessary for asking about violence. The only possible thing I could add to that is ensuring that the issues of violence are never raised unless a person is alone, because we don't want to inadvertently put that person at risk if another person they're with is the abuser. So even for a woman who is there, never raise the issue unless she is alone. It's also important, as our colleague said, to not necessarily use words like violence or abuse. Different cultures and communities have different words for this and different ways of raising the subject. So it's really important to do it in that very kind of organic and natural way to try to increase that level of comfort and trust. And it's also important to never pressure anyone into disclosing violence. It's really up to the individual to decide what they want to do. The job of the provider is to be there as a support, to offer resources to help connect people to what they need, but it's really the individual with their own agency and their own choice to make those decisions. There was also, I believe, that question about the issue of someone not wanting to uptake or issues of a client, I think, not disclosing, accepting assistance, or taking up PrEP. Very quickly, the answer, I would say on that, to try to break that question down into separate parts. I don't think you need to necessarily say, well, you have to disclose, you have to get help, and you have to use PrEP. Again, remembering that we want to root this in individual agency and choice. So while issues around disclosure are very, very sensitive, it might not be safe for someone to disclose, and so try to kind of put that problem in, to the side, and instead focusing on what help can we get this person, what can we offer her, and let that individual make the choices that they want. Part of that is counseling them on PrEP use, how to do that safely, particularly in cases where there are violence. But thinking about those issues, while interrelated, they're a little bit separate. And so try to focus on always keeping that client at the center and really giving them the information that they need to make the choices that make the most sense for their lives. In terms of the questions around referrals, and I know that Robin was going to get to this a little bit, this is a huge issue. We know that a lot of referral networks are nascent and that other community-based services might need a lot of support. I think the important part to remember is that this is why we really are emphasizing this idea of first-line support, or the LIVES framework, because sometimes this really is what a client needs the most. It's that immediate kind of sort of reassurance, counseling, that kind of warm and empathetic response. Not just recognizing that there are oftentimes we don't have the strong community networks to refer someone to, but sometimes it's that immediate response that is given that can make a person feel accepted, less vulnerable, and that there is someone they can turn to and that they can trust. So that's why we're really emphasizing that. I think it's also essential that we work with local organizations, those that focus on anti-violence work, women's rights, PLHIV, LGBTI key populations, to better understand what community resources exist, and to hear from those communities themselves on what the gaps and challenges are and what really is most needed. I think also, particularly in this time of COVID-19 that we are facing with this new pandemic, we're really going to have to think creatively and figure out what we can do to continue providing support using perhaps more virtual methods, bolstering helplines, confidential virtual spaces where people can connect for help. Strategies for doing safety planning during isolation is going to be extremely important as well. So I think these are all aspects of services that will need some particular support during this time. And I'll pause there.
Thanks, Amelia. And I'm just going to say, for those who need to drop off because of other calls, please go ahead. But if you are able to stay on, I'd just like to give the other panelists a moment to comment on or respond to any questions, even if we go about 5 minutes over. So Anne, do you have, there were a number of questions about the work that you were doing, including, you probably weren't able to see them all, including like, is there a package for sender sensitization for providers that can be used where services are not strong? How do you keep the focal points motivated to continue working? Is there any data on improving uptake or retention of PrEP after increasing attention to GBV, IPV? Are you able to respond to any of those, Anne? We don't have Anne. Okay. Robin or Michelle, do you have anything you'd like to add?
Yes, I can address a few of the questions quickly about charisma, and to, excuse me, to go back to the question about what about the men. It's always asked anytime we talk about violence, what about the men, what about the men? And it's an important question, but I do just want to emphasize that the vast majority of victims of gender-based, well, especially intimate partner violence, are women. And so that's why it is, while it's important to think about men, it is really important to just be clear that, women are by and large the most affected population, from intimate partner violence. That said, we are thinking about how to adapt charisma specifically for men who have sex with men, because there are quite high, there's quite high incidence of intimate partner violence in relationships between two men. So and we need to give more attention to those relationships and how best to identify and support men who are experiencing violence from male partners. In terms of charisma, we won't have data on how charisma affects PrEP uptake, because it's all of the participants in the study are being offered and most are using PrEP, but we will have data on how it affects adherence. So we don't yet have that data, but we'll within the next few months. And then someone asked, there are women who, oh no, there was a question about, yes, to Jennifer, her question about, have you considered these tools for other health interventions such as family planning? Absolutely. So our intervention was actually adapted from the Safe and Sound intervention, which was used with women in ANC clinics. And we think it definitely has other potential applications, which we address in the toolkit. I think it's right now it's specific to PrEP, but I think the general approach and the content in the counseling would be easily adapted to other services. And there was one more I was going. Michael asks, for women who are at risk of violence, which module do they receive? And they receive that red module that's specifically about intimate partner violence, that raises awareness about what abuse and violence is. We found that a lot of participants, the background level of violence in the community is so high and so normalized that they don't even recognize that, what they're experiencing in their relationship isn't necessarily that healthy. And then we also talk about the cycle of violence. A lot of, people experience that, but haven't ever put a name or we have this nice visual, and that can help them to sort of understand that cycle. And there's also safety planning involved. And then you ask, do you screen women who might be undergoing some violence as a result of PrEP use? So this is really important that, yes, the screening process does include this idea of, are they experiencing violence in general for some other reason, or is it because of PrEP? But I do want to note that, that some women experience violent reactions from their partners when they find out that they're using PrEP. That rarely happens in the case of an otherwise very healthy relationship. So we've been working on the messaging around this. I don't know if we've gotten it quite right, but I do want to sort of break down this idea of PrEP causing violence. You know, I think PrEP can trigger a violent episode in a relationship that's typically already has some kind of abuse or control issues going on. But yes, that is important to monitor, and we're just releasing well, Liz Montgomery has published a paper last year, and we're now releasing a technical brief that gives guidance to research studies, and it could also be adapted to programs about how to monitor social harms, including intimate partner violence, you know, during the implementation of a study, because that is very important to pay attention to and to know what people are experiencing as a result of participating in a study or using PrEP. We'll stop there.
Great, thanks. And we still have a lot of people on, so I'm going to go ahead and turn over to Robin Dayton to let her make a few comments or respond to questions.
Great, thank you so much, Christine. And I'll actually speak from, so the programs that I am working mostly to support are key population programs. And so we do work with men who have sex with men and sex workers, transgender people, and people who inject drugs. So totally want to echo what Michelle said. A lot of times we do see even higher rates of intimate partner violence among same-sex couples or couples involving transgender people. So this is an incredibly important issue for those populations that are also very much at risk for HIV. And I want to really highlight a lot of the questions came in about how often do you check referral systems? How do you make sure that, or update your service directory? And in our experience and implementation, this is really an ongoing process. So you want to build in a feedback loop where you find out from those who you refer whether or not they even decided to go and get the other services, and that active or warm referral can be a big part of that, and also how those services were. And especially when you are working with, for example, an organization that has historically served cisgender women, but now you're going to start referring men who have sex with men or others to that organization, you really have to lay some groundwork with them first and then make sure that the services are friendly throughout. And some of the ways that we've done that are by convening on, for example, a monthly basis, the different GBV response systems coming together, having people talk through how referrals working, making sure that everybody's receiving friendly services there. And I think, you know, as was said at the beginning, this is even more important now in the time of COVID because different services are popping up and different services are changing the way they operate. So support groups that used to operate no longer function, or they've gone online. Counseling, for example, might only be available through hotlines. So making sure that you are updating that, I would say, really consistently and using the feedback that you get from those who go to get services. Another important way to do that is by offering accompaniment to the services, because that way you get that firsthand feedback from a peer, for example, or a counselor who went with the person to go and receive services. And I think I want to just reiterate a point that several different panelists or several different commenters made about the fact that this does require resources. So having staff who really are tasked with this and making sure these systems function is incredibly important. And I know Amelia and others are thinking about the advocacy side of this, but just knowing that this is something that you really want to dedicate staff and time to and resources as well in order to make sure that when we are sending people out to get other services or when we are providing that GBV response in-house, that it is of high quality. So appreciative that people have stayed on for so long to talk about this important topic.
Thank you, Robin. Liz, do you want to make any comments or responses?
I don't need to make any comments. Thanks, Christine. But I do see that there are a lot of requests for access to the Charisma videos and other resources, and just wanted to, first of all, thank people for their interest in the videos. They really are a cool sort of set of resources, and we will make those, we'll send around links to those videos through your materials distribution following this webinar.
Great, thank you. I'm gonna have you go ahead and launch the survey now, but I'm gonna say a few more words while you're launching that survey. We are going to go through all these questions and ask our panelists to respond in writing, and then we will put them together in a resource sheet that should be distributed by next week, as well as a link to all the PowerPoints and the webinar recording. I really appreciate everyone joining today. I thank our panelists and our speakers, and especially Anne for persevering in spite of a blackout in Kenya. I just wish courage and strength to everyone around the world as we continue to battle both HIV and this coronavirus pandemic. Thank you, and blessings on you. And if you could complete the exit poll before you go, that would be wonderful. Thank you.
It looks like people are still voting, so I'll keep it open for about 30 more seconds.